Are you a healthcare professional looking for a trusted concussion resource? Then you've come to the right place. From her New York City studios, welcome to Concussion Corner with your host, Dr. Jessica Schwartz.
Welcome to the Concussion Corner podcast. My name is Dr. Jessica Schwartz, and I'll be your host for this evening. I am so excited to have Dr. Michael Furtado back on the Concussion Corner podcast for part 2 of, I'm sure, which will be a series of episodes with him. A little recap on Dr. Furtado, just so we can kind of, hop back into where we finished off in episode 1. Dr. Furtado specializes in vestibular rehabilitation and concussion and in managing the recovery of amputees, but is recognized for his expertise through the American Physical Therapy Association as a board-certified neurological clinical specialist with experience in treating all types of neurological injuries. He owns an outpatient private practice in Houston, Texas called AMPT Rehab, where he performs clinical practice and research in patients with vestibular dysfunction and neurological deficits. He earned his Bachelor of Science degree at the University of Connecticut in pre-physical therapy and a Master of Science in PT as well in 2005. He later earned his Doctor of Physical Therapy from Boston University, where he was a practicing physical therapist. For 6 years, he worked as a staff physical therapist for Tier Memorial Hermann Outpatient Rehabilitation in Houston, Texas, serving as in a leadership position such as the clinical coordinator of clinical education and senior physical therapist, and actually creating the vestibular and balance programs in sports concussion and military veterans. His portfolio of professional accolades include various teaching and clinical awards with authorship of book chapters and numerous poster presentations and public speaking engagements. He lives in Houston, Texas with his wonderful wife, who is also a physical therapist working with the pediatric population. And Michael, welcome back to Concussion Corner.
Thanks for having me again, Jess. I'm really excited.
Yeah, I know when we teach together, which we spoke a little bit about in episode 1, I know you and I can essentially talk, for days. So it's always so easy to have you back on here.
Absolutely. Yeah, I look forward to it each time.
So, just to kind of bring our listeners back on track, because this may be their first time, meeting you, essentially, can you just go through a little bit of your why and how you kind of got involved, in vestibular rehab and how that trajectory took you into concussion as well?
Mm-hmm. Yeah. So this practice of vestibular rehab, I would have considered myself a vestibular rehab therapist first, and looking at the various aspects of the injury. And so looking at a dizziness clinic or a balance clinic was my first area of interest. And then concussion sort of evolved in that interest area because of the patients having dizziness and balance issues. So first and foremost, most of my experience came in seeing patients with vestibular problems with Meniere's disease or with hypofunctions or diagnoses like that, which, gave me experience and breadth of knowledge and ability to effectively treat patients in that realm. And then concussion sort of has evolved, like we talked about in episode 1, where it now requires the expertise of someone with this area of practice to effectively manage.
Indeed. And we spoke a little bit in episode 1, just to bring folks back up to speed, essentially on the role of the vestibular system and how it's responsible for, detecting head movement and head position in space, head on body, body on head, assisting gaze stabilization of the visual field, maintaining balance and postural control, providing spatial orientation or perception of body movement. And essentially, the vestibular system, continually is making adjustments, constantly with the cooperation of interacting systems, which I think is so beautiful because this injury of concussion really is a meld of interacting systems and symptoms, whether it be cervical, ocular motor, vestibular, mood and cognition and anxiety and post-traumatic headache or migraine. So it really is amazing, how this almost mirrors the concussive injury of how it has to interact with all systems. And we know that the primary role of the vestibular system is to provide, the central nervous system with information to regulate posture and coordinate eye and head movements. So, can you maybe go into a little bit more depth on the role of vestibular trained physical therapists and, how that essentially is going to be evolving and is evolving now with concussion management?
Yeah, absolutely. So the role specifically of this area of practice for this injury is to assess for those dysfunctions that you mentioned. So if those are the purposes of the system, then we need to effectively test them. And what this injury has challenged us to do is to provide a comprehensive evaluation and assessment that can target the injury and the symptoms that the patient might have. And we have to recognize that there are some deficits in some of the measures that we have. And so the evolution of adopting some of the measures and creating some of the measures is sort of what we are continuing to be in the process of. And so we work with the best that we have now, and with the evolution of more research and better assessment tools as we understand the injury better, then we can utilize those things across practice. But there is definitely an assessment role for these therapists where they need to look at the functioning of the system. So they have to do a comprehensive vestibular evaluation, which includes things like head rotation, positioning, looking at the coordination of the eyes and the head, and then doing effective balance system training by looking at the different systems of balance. And what so much of attention has been drawn to is not only just balancing, but then adding cognitive demand to it, or even adding exertional demand to it. Because many times when we do balance testing, we do it from a static resting state. And so the deterioration maybe of balance after an exertional type of activity is also kind of important. So those are kind of areas that are newer and sort of, learning to assess and to incorporate.
Indeed. And, I'll have David Howell on as well. And he does a lot of our dual tasking, postural, research and publishing the white papers. So I'm excited to actually bring some of, your work and expertise up with him, just because, it's amazing where the research has gone in the last 5 years.
Absolutely.
You were discussing, the fatigue component of this, and we have to remember, in rehab in general, if it's a geriatric patient, a lot of times with the geriatric population, we are, we kind of put our kit gloves on, but we have to remember that folks that are, I think it's 2020. I think it's either 2020 or 2030, but I'm fairly certain it's 2020. By the year 2020, we're going to have more folks that are 65 and over than 17 and under. So we have to remember when we're training folks with like our geriatric populations that we train them with enough intensity to make a difference. And it's so apropos with this injury that, with the concussive injury, I should say, that, demands cognitive demands and attention and has exertional and autonomic issues and vestibular issues, and why it's so important to not just treat one thing. You can't just treat the vestibular system. You can't just treat the headache. You can't just treat the autonomic issue. So it's wonderful to hear that not only are you taking your patients through some exertion protocol, you're adding vestibular and cognitive demands, which is just why, physical therapy is just so valuable for this rehab component of this injury.
Absolutely.
What are you seeing in terms of, or how about this? Let's word it this way: the importance of the subjective report, right, in all of these patients. And essentially, if we just listen to our patients, we can get so much out of them as providers and clinicians.
Yes.
In terms of differentiating, in differentials, dizziness is so common. What are some key things, yellow and red flags, that you're really picking out of the patient's subjective that you're hearing on a frequent basis, or even unfrequent? And we're happy to hear, we're happy to look for zebras if we're hearing hooves sometimes.
Yeah, when that primary symptom, or maybe not even primary, but a secondary or tertiary symptom of dizziness arises, and the patient self-identifies as dizziness as a symptom of their concussion, then my battery of questions are designed to get a info of it. And so with that,
you broke up a little bit there, Michael. Michael, you broke up a little bit. The last thing we heard was battery of questions.
Okay. So I was just talking about, in my battery of questions, if the patient self-identifies that dizziness is a symptom of their concussion, then my role in dizziness and my questions in my differential for dizziness will include things like the tempo of their symptoms. So the timing of when do they come on and how long do they last? So is it a temporary movement that lasts just seconds, or is it a long lasting, they feel dizzy all the time? How intense is the dizziness? So I get a tempo understanding and then sort of a symptom understanding. So dizziness is such a vague term, which really doesn't tell us much of anything. One of my best friends is a physician in the Northeast, and he sees patients in the outpatient practice, and in the medical field, dizziness is one of the top 3 complaints of what patients are seen for in an outpatient clinic. And he hates seeing dizziness because he doesn't have much that he can do for it, and there's little understanding of what it even is. And so when patients say dizziness, I have to get an understanding of what does that mean. Are you spinning? Are you lightheaded? Do you feel off balance? What is that actual feeling like? So after I get an understanding of what the feeling is like, how long it lasts, what the tempo is like, then I just ask sort of circumstantial questions of what are the circumstances in which you're getting the dizziness? Is it after a particular position? Is it after a particular movement? Is it after exertion? Is it after cognitive demand in school? What are the instances in which you're getting it? So that gives me a lot of information that I can start to utilize in my examination, with always the note thinking of, especially with a traumatic injury in our elderly, when their brains shrink and there's more room in the skull for the brain to move, I want to rule out any serious potential of anything that could bleed or has bled. So the cardiovascular system, of course, is always something that is on the forefront of my mind and that I want to rule out as a red flag. So, the stability of the upper C-spine through the transverse and alar ligament, the vertebral artery patency and what that is like, and then any other neurological red flag signs like coordination issues, strength, sensory changes, any kind of cranial nerve findings. Those would be things that in an injury like a concussion would point me towards more serious neurological structural changes that I'd want to be attuned to. So those would sort of be my differential and sort of yellow and red flags.
Indeed, and I think that's so important with the colleague, your cross-disciplinary colleague there, dizziness and even concussion at this point, but they're diagnoses of exclusion. And it's challenging for all healthcare providers because, essentially it requires high levels of clinical skill, which I hope our listeners are paying attention to because this is Michael's world, and a strong understanding of, the sequencing of these proper tests and measures needed to rule out or rule in, competing diagnoses. And quite frankly, causes of dizziness range from, medications and diverse assortment of, vestibular, cardiovascular, metabolic, neurological, psychological, and vision problems. So again, having that stepwise approach of someone who knows what they're looking at so they know what they're looking for is so key. And it's really why you want someone like a Dr. Furtado in your wheelhouse when your interdisciplinary colleagues are treating concussion.
Yes, absolutely. So well-rounded.
Yeah, it's, again, I see it all the time, and I don't know what your thoughts are on this, but, I was trying to treat the neck or I was just trying to do a little exercise with them. But again, you just can't treat one thing. Are you seeing that commonly down by you?
Absolutely. And, for me, what may happen often for me is that because I have the recognition of that area of specialization, many times for me, it's the patient's not many times, but an avenue for some form of referral for me at times when I'm not getting the patient for the first time or in that acute phase of 3 to 7 days post-concussion. If it, chronically 3 months, 6 months down the line, many times I'll have patients who are referred and they're saying, I've tried all these things, but it seems to be a little bit more vestibular and they haven't gotten better. And so they start to get in this wheelhouse of doom, as I call it, where they but that happens often where providers are recognizing their deficiency in this area of practice, and with that deficiency, then they refer out. So I definitely do see that.
Indeed. And hopefully my hope is that in the next 5 to 10 years, we're really looking as physical therapists, as, frontline clinicians for this injury of concussion.
Absolutely.
So what are some common complaints that you're seeing that, hey, maybe your, local providers or, internal marketed patients are coming into you? What are you seeing like common complaint wise? Obviously, they're usually coming in for you for some kind of dizziness issue, but then what are you actually finding that maybe either contributing to the dizziness, that maybe not being quote unquote true vestibular, environmental factors, things like that? What are you seeing commonly?
I would probably say that headache migraine component is probably the most common thing that I see, where it's this questionable source of identification of where it might be coming from. That is the most complicating factor, I would say, when coming to thinking about vestib rehab and the dizziness component. So usually I would say headache, followed pretty closely by ocular motor complaints. Of course, the patient doesn't understand ocular motor complaints, so they won't say I have ocular motor complaints, but they will say things like eye focus, fatigue, those kinds of difficulty reading, watching TV, generation of symptoms that come on after usually activities that I'm denoting that they're saying that there's a lot of visual input. They don't usually say that, understanding that, but there is definitely that understanding by me as the provider.
Indeed. And, that's why I really do favor, and I'd love to hear your comment here as well. What are you finding here? I'll just go back for a second. I really do favor the fellowship trained in headache neurology physician, because with post-traumatic headache and migraine, we know that up to 94% of athletes, and this is just data extrapolated from athletes in a decent sized, and 94%, up to 94% are experiencing headache or post-traumatic migraine after a concussion, which I really do, favor and I am biased towards that headache-trained fellowship neurologist. What are you seeing medication-wise that folks are trying to start with medication or either being prescribed medication potentially from a mismanagement standpoint, or that may be masking symptom, which may be actually prolong their concussion recovery trajectory?
I definitely agree with you about the fellowship-trained neurologist, because there is a difference, I feel like, in the managing provider and approach of the managing provider and medical provider and medical provision. And many times, I would say most of the patients I see, their primary management is going to be of over-the-counter medication for headache. And there's a lack of understanding or awareness of the dosage and frequency of that and the potential long-term use, which long-term doesn't even need to mean very long-term, use of over-the-counter medication, which can result in things like rebound headache, which is misunderstood. So many times they just come and say, well, I was told to take an over-the-counter medication. I was told to take over-the-counter medication. And so usually it's not until the headache becomes a little bit more of a complicating factor, a functionally limiting factor in progress, in return to learn, sport, whatever, where then that neurology referral comes in. And usually the most common thing that I'm seeing is straight to prophylactic medication. Unless they have true migraine, they'll be prescribed the abortive medication, like Imitrex, for example, Maxalt, those things. But a lot of the times they'll get put on a prophylactic medication, which comes with its barriers. Of course, it can be effective, but it comes with side effects sometimes of fatigue and feel like cognitive slowing. But there's that. But a neurologist typically, in my opinion, usually has a well-rounded view of headache and can look at the multi-factors and see, okay, is medicine going to be the best for this, or maybe a conservative approach of physical rehab that might be better, or maybe ocular motor training. So I think if the provider can look at it from that perspective and educate them on medications and over-the-counter medication, that would be a nice, well-rounded approach in trying to manage it.
Indeed, and if our listeners, recall back to Jeffrey Kutcher's, Dr. Kutcher's 2 podcasts we recorded when I kicked off the podcast, remembering that neurologists have recent training in concussion, and yes, neurologists are brain physicians, but at the end of the day, making sure that you are referring or receiving from referrals from a neurologist that understands that this is a rehabilitative injury. So this is not a wait-and-see approach. We have to make sure that these neurologists and our physician friends and colleagues are doing comprehensive physical targeted examinations and not just running SCAT 3s and SCAT 5s on folks and doing a wait and see every 3 months, come back and see me approach. So just really making sure that you're linking up with any provider that essentially really understands this injury so we can help manage that patient back to function. And, Michael was touching on, medication overuse, headache, MOH. And really, the American Headache Society has some wonderful free open access links for providers, which I really do recommend. International Headache Society as well. And just make sure as a provider that you're actually screening, when you're doing your medical screening, that you're screening for over-the-counter medication and other things like that, because they actually, again, as Michael said, maybe either causing the headache or masking other symptoms. So again, really solid points there, Michael. As we have about a little less than 10 minutes left here, can you kind of take the listener through some of what your initial examination process looks like? Because I know that we have folks on here that are spending 60 minutes to 3 hours, either all at once or breaking that up because the patient needs to have that broken up. And I really say this because, quite frankly, we don't do this because we make a lot of money, right? We do this because we love what we do, and we love to help this patient population that's in need. And really, I say this, sincerely, but when our animals are suffering, we put them down. When humans suffer, we don't need to go that route, obviously, but we don't really necessarily care for them as well as we can. So I was wondering if you can essentially take the listener through some of what the initial examination process looks like, the time of that, why or why not you may have to break sessions up due to symptom and things like that.
Yeah, absolutely. Great topic. So as a private practice owner, I can echo your sentiments in that I understand the concussion program is not going to make us millionaires for sure. So it is a challenge because of the timing of how these patients require more care and more time in an evaluation. So if the clinic or the center that the patient is going to go seek care from, if they are not a one-on-one patient-centered facility that has adequate time for their clinicians and for their staff to do these comprehensive evals, then things are likely going to be missed, because from my standpoint, a initial evaluation at minimum usually is 60 to 90 minutes. And usually that is dependent on the patient's symptoms. And my initial evaluation process is geared towards initially giving them some intake information with survey-based questionnaires so I can get subjective reports, followed up with that history taking that we discussed a little bit about to identify yellow and red flags and get a process of how the physical exam will go. And then I usually start with the cervical spine and assessing the cervical spine to check for mobility and stability and issues there. And of course, all of our safety of the upper cervical spine testing. And then usually go into ocular motor testing and do all of my ocular motor tests, look at smooth pursuit, look at saccades, and then move into balance, check some of the balance systems. And usually I finish up with the vestibular system because that's a provocative testing usually. And so I save that towards the end so that, because if I started with vestibular, then I likely would not be able to capture the other information. And so I finished there. And that's not even with doing exercise testing. So usually exercise testing is done the second visit. We're a little bit more conservative in the protocol-based testing in the pediatric and young patient population if they are very acute from their injury. So, within 2 weeks of their injury. So there is a timing response to that we do from a more of a safety standpoint. That exercise testing is usually done on the second visit, sometimes on the first visit if I have that time blocked off. But again, that 60 to 90 minutes, I have managerial input into providing 60 to 90 minutes for these patients because I feel that that's the care that they need and deserve. But that is not, of course, across the board everywhere. But I find that as a concussion clinic owner and developer of a program, I think it is essential to have providers that are doing a comprehensive assessment. So if it's a clinic where they're going to be maybe seeing PT, OT, speech all within one session, then the team needs to come together and divide up those tasks. So maybe the PT can do cervical balance and vestibular. The OT can look at cognition and vision, while the speech therapist also looks at that cognitive piece and how to incorporate that into their functional activities and learn and work and school. So I think if that's the case, then there's more division amongst disciplines. And then again, but you're looking at, probably a 3-hour process. And that is without taking into consideration the patient and if they need rest between these to recover.
Indeed, and it's so important for the listener to hear that, and that's going to be a repetitive theme on the Concussion Corner podcast, not because I'm telling anyone to, impart that information on our listeners, but this is just what best practice looks like present day in 2018, and that may evolve later this year or in 5 years or in 2 years, but, so important to hear Michael essentially discuss how he's taking his evaluation process from a least provocative to a more provocative state. Because again, we want to make sure we're not getting false positives on every patient that walks through the door that has a concussion. So very important there. Awesome information. As we kind of wrap up shop here, Michael, I was just wondering, if you can comment on common trends that you're seeing in your persistent symptom patient population that maybe didn't access you in the acute phases and maybe has kind of gone down that downstream trajectory or pathway of, mismanagement or not seeking medical care, right away or so on and so forth. What are you seeing down by you?
Yeah, so the common trends in that patient population that I see most commonly are things like mood and personality, psychological differences in ability to cope and manage. And so there's high levels of anxiety, maybe even depression. And from it very well may be not premorbid, but simply because of the longevity of symptoms. And it was sort of, is it the chicken or is it the egg? And sort of it's what has happened because of the concussion and what has happened in their functional life. And so I definitely see that there is a lot more of that chronically, which we need to manage. We see it acutely as well, of course, but there is definitely an ability to have to manage and be your patient's biggest cheerleader and normalize the experience for them quite a bit. And so I feel like there is a lot of coaching in that patient population and normalizing the injury and saying, look, this is a normal consequence of the events you've sustained, and anyone would go through this natural process. And so we will start, these are the findings that I have found on examination. And then in the management, I find that I always just break it back down and start again from step one and just slowly build them up and have them achieve milestones along the way. And so then that can sort of break the mood cycle and kind of give them some victories to be that have an ability to kind of succeed on. But, breaking it down, I don't really go to where they fail. I want to maybe start where they succeed first and foremost. And, of course, the chronic headache, which we touched upon earlier.
Indeed. And Michael discussing the normalizing the patient experience is so important, understanding if it's chicken or egg. Again, all of these, and historically, as we finish up here, historically with this concussive injury, what we've seen is that two trajectories, usually get taken when we don't know what to do with a patient in medicine. We either lead them down that trajectory of, they may be malingering and they have to be faking it, or we refer them to psych. Now, the psych component is not necessarily alluding that we assume that they're quote-unquote crazy. I use that very loosely, of course. But again, if we're seeing things like anxiety or depression, those things can be seen by an unskilled or untrained eye. Family members, coworkers, things like that. But we have to make sure that we're validating that symptom profile from that patient, because they may be feeling all of those things because they have space and motion discomfort. They may be having vestibular migraines. They may be having cervical spine whiplash associated disorder discomfort. They may be having ocular motor issues, which all have an anxiety, including post-traumatic headache and migraine, all have an anxiety overlay to them. So if your patient is concussed and has all of the above, they should be anxious, because if they're not, there's probably something wrong. And that may be a different type of mood disorder. So again, so many valid points there, Michael. It's so awesome to have you on again. And I know you're going to be a consistent guest here. What's the best way for folks to kind of reach out to you and find you on either social media or find you at clinic?
Yeah, absolutely. I am reachable by many different platforms. I'm here in Houston, and I love to collaborate, and I love to travel as well. So I love to visit different places. So I'll probably see professionals around in conferences and such. But otherwise, my social media, probably via Twitter, is an easy way to contact me. My Twitter handle is MIFURTADPT. So me for Todd PT. And then any emails on specific clinical cases or research or opinions can certainly come to my work email, Michael, MICHAEL, at amptedrehab.com. And amptedrehab.com is our clinic website, so feel free to search it out. And if you need any resources, just reach out. And I love to collaborate and talk about this stuff at any time. So feel free to reach out to me.
Indeed. And I comment on all of our folks that really come on this podcast of Concussion Corner and just really connect to the benevolence and kindness and giving to each other. Because again, folks are just trying to build each other up so we can get the message out there and just help as many people as possible. So, I don't want to say take advantage, but, take advantage to an extent, with reasonable expectations that we all have busy schedules. We're managing probably more than one job or multiple, gigs, as we all do in healthcare often. For me, it's to pay off those bills. It's also because I love it.
Absolutely.
So just be patient with us if you reach out to us with long emails and patient care and things like that. But we're always here to help and, again, connecting to that wonderful community of this concussion community that I've really been surrounded with in the last 5 years. It's been a wonderful journey. And I'm so humbled to have you as a friend as well, Michael.
Oh, absolutely. I really adore that and really cherish it quite a bit.
Awesome. Well, I will let our listeners go, and I hope you have a great clinic day, and good luck to your patients down in Houston today.
Sounds great. Thanks, Jess.
Thank you for listening to the Concussion Corner, hosted by Dr. Jessica Schwartz. The information in this podcast is for entertainment purposes only and not to be used as personal medical advice. Don't forget to follow us on social media on Facebook, Instagram, Twitter, and YouTube at Concussion Corner.